ଯେଉଁ ଆପଣଙ୍କ କ'ଣ ଟିକେ ପ୍ରୋବ୍ଲେମ୍ ଥିଲା, ମାଇକ୍ର ପ୍ରୋବ୍ଲେମ୍ ରହୁଛି, ଏଇଟା ସାଉଣ୍ଡ ଚୁଣୁଥିଲା, ଦେଖୁନାହାନ୍ତି ଚୁଣୁଟା ଆସିକି ମୋବାଇଲଟା ଦେଲା ବେଳକୁ ଠିକ୍ ଶୁଣିଲା।
ଆରମ୍ଭ କଲେ କି ନା? देखना स्टार्ट करेंगे। Upon early all
right now low what happened?
yes, audible. That.
You see the slide? That's what I'm telling.
Okay, now it is audible. Now you can start.
Can you see my slides?
Yes sir.
Oh, that's fine. Right. Sorry. My apology for the delay. Actually, there was some problem going on. That's why I couldn't able to open it.
Okay, sir. Okay, sir.
Yeah. It's fine now?
Yes, sir.
Okay. Yeah, thank you so much. Thanks. Thank you so much for your patience. Here today I'm going to talk about, I'll give an overview of the general cancer as well as I'll tell about my work a little bit. I kept all my slides, for my better understanding. So my topic is like simultaneously hitting multiple targets to attack non-synthetic lethality phenotype in cancer, a road to cure. So I just put this photograph because I'll just give a hint about this institute. This institute is among the 38 institutes in USA that are mainly focused on the cancer research, and they are designated as National Cancer Institute. So I'm very lucky to part of a hereditary institution, and I'm also lucky to have to do such innovative work on the current cutting-edge science over here. So, first of all, I would like to say that I'll speak about two things, two objectives in a whole slide for topic of 1 hour presentation. So, I'll say about the overview of cancer and how we can treat the cancer and different approaches to prevent cancer. And the second part of it will be novel multi-targeted drug, aggressive B-cell malignancy or B-cell cancer known as mantle cell lymphoma. So let's go to the original slide. And on the first slide, as you can see here, I just put a heading, what is cancer? So when we heard this topic, when we heard this disease, people here really think about what exactly it is and how devastating this disease is. But in a research and a research perspective, I would like to say that I'd like to say what causes cancer, what the reasons and what the root behind causing cancer, and what the links, what the genetic links or epigenetic links that leads to that develop the cancer progress. And the other way, once I find out, see whether the cancer progression, I would like to see how to diagnose, proper diagnosis. Because cancer is a disease, you need to have a proper diagnosis state, otherwise it would be late to find out a cure for it. So other things would be how cancer be prevented. Can you prevent cancer by your own consent? Or can you prevent it by therapeutic drugs or treatments, different treatments? So all these things I will include, I included in my speech. Yes?
Can I interview you? Because your slide is not so. Only your figure is there, but your slide is not so. I think you stop presenting. You summary put your bottom of stop presenting. You just show up your slide.
Can you see now? My presentation?
No, it's not exactly shown up right now.
Can you see the slide? I think you can see the slide. Yeah. Is it perfect now?
I
is perfect. Now can you see this slide? No? Can you see now? Excuse me?
Yes. Still not showing anything. Only you
ନା ସେ ନିଜେ ସେୟାର କରିବେ ଆମର କିଛି ପ୍ରୋବ୍ଲେମ୍ ନାହିଁ ତାଙ୍କ ଆଡ଼ୁ ସେୟାରଟା ସେ ଦେଖିବେ
Is it perfect now?
ओके सर
Can you see now?
हाँ यस सर
Yes. I
Yes, sir, it is showing.
yeah. So
Sir, your vision and slide is showing.
okay, yeah, thanks. Let's come to this slide. Now, where the basic slide where it's showing the tumor progression. So before seeing the tumor progression or the cancer cell development, first we need to understand what is the normal cellular division. I'm getting some background noise, please. Can you cancel the background noise? Okay. So we need to understand the basic normal cell, basic cell division. Especially, we'll see what the normal, how the normal cell divide and how the cancer cell divide. Although both systems operate the same way, but in normal cell division, as you can see here, the parental cell here, they divide through mitosis and give rise to equal daughter cells, and means they are totally similar to the parental cell. And when they divide, and the divides are in numbers. One daughter cell again divide to another, one parental cell again divide into two daughter cells. So and this process continue and continue. So when it reaches a stage where it's spontaneously distributed a death or a death process program, death process which is known as apoptosis, program cell death. As you can biologist, you must know that normal RBC, red blood cells, they expire in HN1 days. That means they are directly undergoes the normal cellular apoptosis system. So, but in this the cancer cell, contains the cancer cell division. The cell division operates the same way, but and you can see instead of having a red mark here, that means that having a mutation in the cells, and once this mutation occurs, and it divides into mitosis and divides into daughter cells, and this mutation equally divided and accumulated in the daughter cell. So when the cancer cells accumulate mutation further, and again divided into other daughter cells, and again the mutation accumulated here. So it will pass from one generation to next generation, and when it passes one generation to next generation, the mutation already accumulated a lot. And this leads to a mass of cells or monster cell, which is called as cancer cell, or we can say that is the mass of cellular tumor cells or malignant cells. And this mutation occurs due to several factors such as environmental stress and genetic factors involved in this, or maybe some molecular differences in mechanism. So like here you say a gene mechanism or gene damage. Once the gene damage occurs here, you will carry the same process over years and years and therefore this mass of cells. That means the error that occurs here, it cannot be repaired properly, and the error continues from one generation to one generation and then leads to cancer cell, mutated cells that eventually leads to cancer cells. So now let's understand how the cancer cell divide and how it generates from the normal cell and how different from normal cells and how he can make cancer cells. But the main thing is that what are the characteristics of cancer? What properties of signal event or the mechanism that leads to progression of cancer? Program death on the apoptosis, but the tumor cell avoid this process. The tumor cell, the cancer cell will avoid this apoptotic process, and our cancer cell never come for the death phase. It will always carry on mutation and keep on going, dividing to the terminal stage. So they really avoid the apoptotic events. How the apoptotic event occurs? The apoptotic events is due to the limitless replication. So what is limitless replication? The DNA that synthesized is a process known as replication. So in tumor cell, to survive or to grow, it need to have its own replication, its own transcription, its own translation program. So once the DNA synthesized cannot survive, it must that's because of this limitless replication. The other most important thing is the tumor emergent metastasis, which is the very significant characteristic of the tumor. So metastasis means the tumor primarily grows in one part and it migrates to other parts, other organs of the body. That is known as metastasis. From one primary cell to another secondary cell. And the metastasis you will see on the slide of the metastasis. This is the first stage of the tumor. Another is another property that helps the tumor cell to grow, helps the tumor cell to change its place from primary cell to secondary cell. And the genesis property is the tumor cells to add an oxygen from the nearby cells, and it helps to grow faster. So the most important thing that we will discuss on this slide is the tumor metastatic process. That is the most common process that is important. So we all different stages of cancer. So we all people know that we are always talk about the different stages of cancer, represent having cancer in the first stage or last stage or early stage of cancer. And after cancer stage, therapy. So the first is the tumor cell, the mutation arises in a cell, and that mutation leads to the second phase, the next first phase. Hypoplasia is nothing but the tiny growth or overgrowth in the organ. And the second stage is dysplasia. So now when you move to dysplasia, the second stage, so it is like microscopic growth. So where a pathologist or pathologist can say whether this tumor growth is due to is cancerous or it's dividing fast. So it's a microscopic cancer where you can find out that precancer is when it's already in a lab where the tumor everyone has already been cancer.
ସବୁ ମ୍ୟୁଟ୍ କରିଦିଅନ୍ତୁ ସବୁ ଭିଡ଼ିଓ ଅଡ଼ିଓ ମ୍ୟୁଟ୍ କରିଦିଅନ୍ତୁ ଏଇଟା ମ୍ୟୁଟ୍ କରିଦିଅନ୍ତୁ ବେଶୀ ବଦମାସି ବାହାର କରୁଛନ୍ତି
So this is where the survival of the patient is very, very less. So we'll discuss this metastasis. This process is from the metastasis process. So we'll discuss about the metastasis process from my side. So what is metastasis? As I said to you last slide, when the primary chemotherapy occur here, the other part of the body or other organ, that process is called metastasis. So here you can see the primary tumor method. So like give an example, like suppose this happens in the liver. This tumor is identified in the liver. Then you usually has liver. Here the cancerous one, and it will immediately migrate to the healthy tissues of the liver. So once it uploaded or once it reaches to the healthy side, the healthy tissue of the liver, it will start bloodstream, where it will stay for a longer time, or it will metastasize, or of origin that can or on a different side. So it provides some process where it can stay in the bloodstream, immediately come into the bloodstream, and it will start circulating throughout the body. So they can survive for a long time because the blood oxygen from the blood, so they can survive for a long time. Once they survive for a long time, immunocells or like these cells or immune compartment, they come under each of these cancer cells and they try to pressure. When they pressure sometimes in the blood cells try to interact with these cancer cells and they try to, once they collide, they will fuse the cancer cells, they will come out from the surface and they will start accumulating in the stomach. So these are the cancer cells that due to high pressure in the bloodstream, they will come out in the stomach. But once they reach the stomach here, they will start growing indefinitely. They will proliferate indefinitely and they will start forming a new cancerous cells in a different organ. And they will start making a cancer cell in the brain. That process is called metastasis. When they form a micrometastatic formation, they will grow bigger and they will cause color. It's called metastatic color. And once they got color, they will eventually spreads every part of the body. And that leads to patient chances of survival is very, very less and this is terminal state. So here, the patient ultimately goes to death. This mechanism is truly a working mechanism because if we stop this progression or metastatic progression, we can really stop the cancer cell death. So here I can show an example here how the metastasis occur here. So you can see, suppose this is the breast cancer, you can see the primary tumor occur here. Eventually migrate to the solar plexus, you can see that is tumor or the cancer cells in the bone. So you can see this is a common phenomenon of metastasis like breast to bone, breast to brain, or to lungs, or
ఇక్కడ లైవ్ చార్జ్
so this is
మనుషులు కొట్టాలంటే జోడు జన చెప్పారు
So if you look at the scenario, the world scenario of global cancer incidence, so you see, so like the Western, like Western cities, states, the countries like USA and Europe, they are having, the 21% of, cancer occur per year, whereas Europe is 23%. You can see a 48.4% cancer, global cancer incidence in Asia, especially in South Asia like China, India, Pakistan, and these. So it means that the cancer death worldwide, lung cancer is the most predominant one. You can see the highest number of deaths in lung cancer followed by liver, stomach, bowel, breast, esophagus, pancreas, prostate, cervix, leukemia, and other cancer. So the lung cancer is the highest mortality rate because we know that frequently consuming tobacco, smoking cigarette, so that's the lead cause of death. So what is the cause and potential preventive factors or estimate percentage of cancer case? So as I said, that tobacco is a high, cancer-related, causing cancer. Almost 33% of tobacco consuming people having cancer lungs or even like oral cancer. So excessive weight and obesity, high weight people are susceptible to get cancer at least 20%. Diet, 5% lack of exercise, 5% occupation means people are sitting in office for a whole day without doing any work or without doing any physical exercise. It contributes to 5% of this. Even highest like your virus causing is 5%. HPV virus, family history or another alcohol consumption is about 3%, pollution and other factors. But the question is, can we prevent this cancer spread? Can we avoid other people to follow the strategy to prevent the cancer? So, how can we prevent the cancer? Or what is the recommendation that the organization has given to prevent the cancer? So, here the treatment methods have been like you susceptible to cancer, and physically active, at least exercise tolerance, other sources like these, fast food as well as the processed food, fats or sugars. So that is another cause of, most of people limited consumption of red and processed meat. Because this consumption of red meat really has a bad impact on your body metabolism. So limit consumption of sugar as well as the cold drinks. So we all like to have cold drinks, thumbs up, Pepsi, everything. So need to check into this because this sugar consumption leads to obesity, and that obesity leads to higher rate chance of cancer progression. So like the same way like alcohol consumption, as I said, alcohol consumption is associated with different cancer, cancer or even oral cancer or throat cancer, mostly the throat cancer, which is occurred due to the high consumption of So,
ସେଇଟା ପୁରା ପରିଷ୍କାର ଯେଗୁଡ଼ା କ'ଣ
so these are the potential
Right.
things that we can take care of and we can lead the life.
ମୁଭମେଣ୍ଟ ହେଉଛି ସେଇଟା ଡିସ୍କସନ୍
Other
କରୁଛୁ
than we can keep away the cancer from us. So I talked about the potential, prevention method that we can take to prevent cancer. But once the cancer occurs, what is the strategy need to be take care to prevent or to tackle with the cancer progression? So here I am sharing the slide that shows a potential cancer treatment strategy. What treatment options are available to treat a patient? So we can say the first, you can say the immunotherapy. It is a therapy that associated with the immune function. They can use the immune cells so that they can eradicate, they can clear the cancer cell from your body. Or some of
ଗୋଟେ
the
କଥା କ'ଣ
tumors
ସାର୍
that they are
ଯେଉଁମାନେ ବି
associated with
ଆଟେଣ୍ଡ
this
କରୁଛନ୍ତି ସେମାନଙ୍କୁ ବୁଝା କଥା ଯେ ସାଉଣ୍ଡଟା ମ୍ୟୁଟ୍ କରିକି ତୁମେ ରହିବ ତୁମ କନସିୟସ୍ ଗୋଟେ ରହିବା କଥା ନା ପିଲା ଆମର ଗପି ଯାଇ କରୁଛୁ ମାଲ ଯାଉଛି ହେଇ ପିଲାର ରାଗ ରଖେ ଗୁଡ଼ା ରିମୁଭ୍ କରିଦେ ସାଙ୍ଗେ
to boost up or to increase the T cell population so that the natural T cell function now it is having impacting the therapeutic perspective the immunotherapy. And second, that is the solid tumor always radiation therapy because radiation affects MRA that highly penetrated to the tumor and then try to board the tumor and clear up the tumor.
ଘରେ ବି ଝିଅ ବନ୍ଧୁ ଜଏନ୍ କରି ସମସ୍ତେ ଜଏନ୍ କରନ୍ତୁ ଯେତେ ମୋବାଇଲ ଅଛି ଏ ଲୋକ ସଂଖ୍ୟା ବଢିଯିବା ଦରକାର ଶୀଘ୍ର ଜଏନ୍ କରିକି ହାତରେ ମାତ୍ର ଦେଇଦେବ
Another approach where you can target a specific target or specific protein. You can shut down that protein function side effect, other that's a toxicity. So we'll discuss and the bone marrow transplantation you are having liquid malignancy. So you must have heard about this report that he has undergone bone marrow transplantation after having so this is another strategy to remove all the bone marrow from the bone marrow blood cell and infusion with a fresh clot. Surgery, as we told, surgery is the primary therapy of this solid cancer. That will remove the mass of the tumor or the tumor mass through surgery. And the last is the hormone therapy. So here I will, from here, I will concentrate on two aspects, and one is the targeted therapy, what exact targeted therapy is, and why the targeted therapy is mostly, required to treat the cancer patient. And another thing we'll talk about the chemotherapy. And these two approaches are currently undergoes clinical trial, and patients are treated mostly with these two therapies. One is targeted, one is your chemotherapy. So if you compare with the chemotherapy versus targeted therapy, there's a lot of drawbacks in the chemotherapy. So you can see here is the figure I could take for you guys to understand. So what is chemotherapy here? The drug that affects cells that are dominant, not yet very specific as I said, mostly intravenous, means they can give it through IV, and potential very toxic cells. So the chemotherapy, you can see here, if that person with blind eye, he is having a gun and he is firing. When you any part of his face. So it's not specific. And same as this guy, he is also firing. And, you can see it is he is firing multiple times. It is hitting nothing because it's unspecific. You can see he is going here, going here. So the point of showing this tattoo is represent the chemotherapy. The chemotherapy is not specific and high cost. When the targeted therapy is very specific and it only targets the particular cancer cells without affecting the normal cells. So you can see, suppose this is a cancer cell here, and you are treating with cancer cells with this chemotherapeutic drug. And once you treat the cancer cells with the chemotherapeutic drug, it kills the cancer cells as well as it kills the normal cells. When the drugs that kill the cancer cells as well as the normal cells, the cancer cell, when it kills the cancer cell as well as the normal cells, that means you can see that patients having a chemotherapeutic regimen or chemotherapeutic treatment, people are getting sick and they are totally weak and lean because of the problem of killing of the normal cells. And the normal cell killing, suppose I'll give an example like your, suppose you're taking chemotherapy and the patient internal nuclear layer, they also died and patient used to vomit, vomit and get sick each and every day. But when in targeted therapy, we can target the specific cancer cells without affecting these normal cells. So this is the well supported therapy or well suggested therapeutic option for treatment of cancer to target instead of chemotherapy. So as I said, the targeted therapy is more prevalent and more effective as well, with reduced toxicity or reduced normal cell killing. So, but still, the targeted therapy has even some drawback, and the drawback is the resistance. And this is the main area of research, that how the drug gets resistance to the tumors or to the cancer cells. So there are different parameters to measure the drug resistance. So I can here the first thing is the decreased uptake of drugs. When a patient treated with a particular targeted therapeutic drug, the cancer cells always evade from this and they are unable to take the whole drug. They will efflux out the drugs, or they may not accept the drug. Suppose you are giving 30 mg of drug, maybe the cancer cell is taking 1 mg of drug, which is not sufficient to kill the cancer. So that leads to drug resistance. So another is the increasing drug metabolism. When a patient consuming a drug that for the treatment of cancer, the drug itself metabolized in the body by the liver microsomal, because when you consume a drug, when you are administered a drug, the liver microsomal enzyme that will immediately start breaking this drug. Once it breaking this drug, the drug will come out in a form of excretion. So the half-life of the drug will be very less. If the drug, if the drug stay for a longer time, then it's effective. If the drug break into smaller part and they excrete from the body, there is no, there is no way to, to kill the cancer cells, and that leads to the drug resistance again. Another way of drug resistance is also drug targets. Suppose a drug binds to a target molecule, and eventually after 3 to 4 cycles of exposing the drug, the target itself gets mutated. As a result, the drug cannot bind here and cannot suppress this particular protein or gene function. As a result, the drug cannot work for the cancer cells. So this is another form of drug resistance. And the same way they impair apoptotic pathway, as I said, they suppress the apoptotic pathway and they evade the apoptotic And some of the drugs they inhibit the cell cycle checkpoint, where they inhibit the proper cell cycle regulatory system and often lead to drug resistance. It's another form of drug resistance, the efflux pump. The efflux pump is nothing but when your body accepted outside the molecule or drug, the cell cannot immediately formulate. It will try to efflux out. It will try to cells never want a toxic substance to come inside. It's like when you don't know a person, there is no reason to ask him to come inside your home. The same way, when the cell recognize the drug molecule, it will start efflux out from the cells. So when the cells will not present in the cell, then the drug won't work. As a result, the drug resistance. So including all these phenomena of drug resistance, and understanding this drug resistance and how to overcome this resistance is a great hurdle in cancer treatment. So this resistance pattern, if we ask whether can we overcome this phenomenon? Yes, definitely we can overcome this phenomenon. And how? The question how we can overcome this drug resistance. So here is the point comes that is known as targeting synthetic lethality targets. What are synthetic lethality targets? We need to understand this. This is a new concept in science, that came out a few years back. That the synthetic lethality. What is a synthetic lethality target? The synthetic lethality targets may be a protein, maybe a kinase, maybe an enzyme, or maybe epigenetic modifier, etc. So we'll see what the synthetic lethality is and how it overcome this resistance that occur by the drug. So to understand the basic concept of synthetic lethality, so you can see that simultaneous inhibition of two gene functions that leads to cell lethality of the cell or cell death. And this inhibition can be through genetic approach, through siRNA, or through genetic inhibition like CRISPR method, or through pharmacological inhibition. So pharmacological inhibition means administrative or exposing a drug to the cells that can lead to simultaneous death. So if you can see, for a better understanding, suppose I have two gene partners, gene A and gene B. So when these two partners are present, the cell is happy and the cell is proliferated and the cell is viable. No death occurs. Even when I am trying to suppress this gene A function, whereas keeping this gene B intact, still you can see the cells are viable. The same thing here, if I keep the gene A intact and suppress the gene B, still the cells are viable. But when I am trying to suppress both gene A and gene B, the cells undergoing lethality, means the cells is going to the death phase, is dead, well is dead. So this concept is known as the genetic synthetic lethality. The same approach that has been taken is called pharmaceutical a drug-induced synthetic lethality. What is drug-induced synthetic lethality? So you can, as I said, this is a viable cancer cell. When we are, suppose a patient having this cancers, and we are giving a treatment option as a drug. So we see that the cancerous cell is still viable, still alive. The drug has no effect on this cancer cell. And the same way, if we try with another drug molecule, individual, because these are individual drugs, two individual drugs. The same happens to here. But you can see here, when a cancer cells of a patient administered with two individual drugs, combination of this and this, the yellow and the green, you can see there is the cancer cells started dying, or it's lethal. So this phenomena has been studied in my lab. My professor, Dr. Durden, has shown a horizon of making a combinational drug approach to kill the cancer cell through a synthetic lethality approach. So this study, the study has been, we are pursuing this study in different cancer models, and we have the data that we are getting, when we are combining two different drugs, we could able to get highest antiproliferative effect of cancer cells. So as I said, the two combination drug, when we are giving two combination of drugs, and how effective it is as compared to a single molecule. So here a model I want to show you today, that we are providing single inhibitor in drug A and drug B. When we are providing this to the mice, when we are injecting into the mice, you can see that drug resistance occurs. So when we are providing two individuals, and tumor relapse means the tumor again occurs. Refractory means totally the drug may not work for this tumor, and low survival, the chances of survival is less. When we are combining two individual drugs, we can see it is better than the single inhibitor alone, which partially overcome the resistance, low chance of relapse, high efficacy because of combination of the two drugs, 1 plus 1, so high efficacy. And other is the cons is the high toxicity because when you are administrating two individual drugs, ultimately it will induce high toxicity and different cell penetration. Yeah, when you are administrating two individual drugs, you just consider as a patient when we are administrating two individual drugs to a patient. The cancer cell may not carry this. All cancer cell may not carry these two drugs at a time. Maybe one cell will get this, one cell will get this. So there will be no combination approach. So that's why we have, especially our lab has developed a multi-target inhibitor in a single molecule, where a single molecule having both the targets, A and B targets, or A and B drugs. When we expose into the mice bearing a tumor, we could able to see that it ultimately overcome the resistance as compared to these two processes. Low chance of relapse. You can see the chance of relapse is more or less. High efficacy because one molecule hitting two different targets ultimately gives rise to high efficacy. Low toxicity because one molecule will provide. So that's why it's, as compared to this combination, we are giving one drug with two different targets, ultimately reduce the toxicity. And of course, it's a cost effective. A patient cannot buy two individual drugs, but a patient can buy a single drug. It should be affordable to the patient. So this, including all the factors, we have developed this molecule, and we are currently, studying this multi-target inhibitor. So second half of my talk is, as I said, that I will talk about some of my work that I have done past few years. I'm working on a cancer B-cell lymphoma cancer model, which is called as mantle cell lymphoma. It's a lymphoma, highly aggressive B-cell lymphoma. The B-cell lymphoma is kind of like it's occurs in the blood cancer, we can say, the B-cell lymphoma. It's a non-Hodgkin lymphoma, with an overall poor prognosis and survival rate is 3 to 5 years. So it is highly aggressive as I said, and very incurable due to the eventual development of drug resistance. Overexpression of certain proteins like a cyclin D cell cycle protein that and the mutation that occurs results transcription, chromosomal transfer. Some of the transcriptional factor like c-Myc, which is the pro-oncogenic or oncogenic protein that eventually leads to most of the cancer progression, not only the mantle cell lymphoma but other types of cancer as well. So another is the activation of B-cell receptor pathway. So before understanding the concept of the disease or the disease progression, we need to understand how this mantle cell lymphoma occurs, and we need to understand the molecular basis of the B-cell lymphoma. So every cell has a certain receptor, the same as the B cell. The B cell has a receptor which is certainly called as BCR. So this is the receptor, and this is the extracellular portion, and this is the intracellular portion. When these two receptors come close to each other, mechanistically this lean, these are called as SRC kinase, SRC protein, the lean and C, they come close together, and they in turn activate some of the signaling molecules that are really affecting the B cell malignancy. And mostly important is the BTK. So it's a kinase, protein tyrosine kinase. So it is the intermediate step that overexpression this intermediate stage BTK leads to the B cell lymphoma. So if we stop this BTK expression by using a molecule known as ibrutinib, ibrutinib is a drug that provides to the patient those who are having CLL or NCLs, chronic lymphoma, that is all blood cancer. This drug is well proven, and the FDA has already approved this drug for patient having the blood cancer. So this molecule, if we administer this molecule, it will suppress this kinase function. As a result, the B cell, the mantle cell lymphoma or B cell malignancy shows strong anti-proliferative activity. So, but they're having some drawback when we are administrating this ibrutinib, because targeting BTK with ibrutinib is highly effective in NCL, and due to its resistance nature, means however the relapse is virtually inverts universal aggressive proliferation of core progresses. Because of this resistance pattern, the cancer cell again relapse or again back to the normal progression. So this is the main step where our lab is trying to work in that how can we stop this BTK expression so that it cannot be, the tumor cannot relapse again? How we can develop a molecule which can stop this BTK function and avert the relapse? So, as I said, this ibrutinib is a first-in-class inhibitor of this BTK. It's a highly potent inhibitor with IC50 is nothing but 50% inhibition capacity, which is like very less, 0.5 nanomolar. It's an orally given drug for the patient having blood cancer. But as I said, the main drawback of this drug is often it gets resistance. How it gets resistance, you can see this right hand side. So this is the active site here, and this is the
Sir, one second. Sir, your presentation not so.
Excuse me, Captain. Are you? So this
No sir, no
this
sir.
is an active site.
Sir, your presentation not so. Sir, sama kan mana itu sharing kuri mana misalnya jangan nanti kuri chance latih sih. Keren kok.
No, sir. This is an active site.
Okay sir. Okay sir.
Okay, now sweet.
Okay.
I'll just keep this slide like this, so maybe there's a problem when I'm expanding the slide like this. So I'll keep the slide like this. So Is it well visible to all of you? I think.
Yes, sir. Yes, sir.
Okay. No, thank you.
Okay, sir.
So here you can see the active site and the protein bind here. Once it bind here, it make a lock and it would like to remain. So after a repeated cycle of drug exposure to the patient, the active sites of this BTK, the kinase, it get mutated. As a result, the drug cannot fit into this, active sites. So once the drug this ibrutinib unable to fit here, the cancer progression still goes on, but the ibrutinib is still not available to, available to this BTK. As a result, the proliferation of these cells. So here is the strategy to make how to overcome this resistance pattern, how to overcome this mutation, and that eventually leads to anti-proliferative activity of these B-cell malignancies. So our strategy in my lab, our strategy is to, if we inhibit BTK as well as the another partner protein PI3K, so we can partially, stop the cancer progression, and we can partially overcome the resistance that occurred by ibrutinib. If we inhibit both these pathways, BTK and PI3K pathways simultaneously. So our lab is working on this aspect, and we have developed some of the molecules, or some of the drug molecules that can inhibit both the pathways simultaneously, so that we can get maximized cancer cell death. So we have studied a novel receptor inhibitor. The SRX is our company, the company called Signal RX, that we have
ताली मारेगी सारे
you can see we have made this molecule.
इधर देखा
I approach you know able to give this that idea. So we haven't published. That's why I could not able to provide with the structure. But yes, this is the molecule. This is having three different targets. One is PI3K, as I said in the earlier slide. Another is the BTK and the BRD4. This BRD4 is the epigenetic effector molecule, and BTK, as I said, that is one of the intermediary protein or kinases in the B cell receptor pathway, and another is the PI3K pathway. So in these three targets at a time, that gives you a strong anti-proliferative effect or strong anti-cancer. So we have developed this molecule by in silico approach, by computational method of designing this molecule. Once we design this molecule, then we have synthesized this molecule, and then we validate the structural affinity by crystallography or NMR study to show the drug is perfectly bind to this target. And further to evaluate this drug action in vivo and
recording data show
the cell culture model. So one aspect of making this triple inhibitory drug to see whether this inhibiting target that's easy and that it has always a chemical molecule exerts definitely amount of toxic effect. If it is having like off-target effects, our drug is inhibiting A, and it will inhibit B and C. That will B, C are the off-target effect. Once it start inhibiting B and the C, the cancer cells will exert toxic effect. So that's why we need to see the specificity of this molecule. So we have profiling with the kinome profiling is the tau. There are 282 kinases in the cells that we have profiled. So once you profile, you can see that there is strong affinity rate around. You can see that highly specific. This drug is highly specific to these targets. Whereas same as when we target this BRD4, you can see it's very specific for BRD4. So this is the first stage of drug making, where you can see the drug is more specific towards the target, and target is and the target's effect is simultaneous. The effect is totally at a time inside the cells. Next, we try to see this effect of this drug molecule in different cancer models, like different cell lines, cancer cell lines. Here we can see we have compared this drug molecule with our drug molecule with the existing drug, the protein. So we can see here that the drug effectively target these targets and leads to cancer cell death or the B cell cancer. So we know and these cells are MCL, mantle cell lymphoma cell lines. You can see when exposing the drug, the cancer cells are going to die. This is a death rate. Here you can see the 50% death here. Almost all drug concentration that cell we observe in the Z138 cells. One other thing is how is the drug effective to the normal cells? It should not kill your normal cells. So that's why we need to take the normal splenic B cells, where you can see when we are administrating with our drug, 3 to 6 with our drug, you can see there is a parallel, there's no death atom. Means the 3 to 6 is specifically to the cancerous cell, they are not affecting any of the normal cell. But whenever providing a combination of drugs that are only existing drugs that's known to inhibit cancer cell, they produce high toxic effect. You can see the toxic effect. Another, the tonsil, we check this drug effect on the tonsillar epithelial cells, where you can see that addition of our drug 3 to 6 to able to restore the or avoid the cytotoxic death, normal cytotoxic cell death, whereas administration of all 3 drugs induce death. That means our drug, our molecule is totally specific, target specific, and is less toxic to the normal cell and highly potent against these cancer cells. So that's the first evidence gave us that this drug has the potential to target the B cell lymphoma cells or B cell cancer cells. Then we saw the apoptotic property of this molecule of these drugs. Here you can see that when we are providing this drug to the cells, apoptotic means number of deaths. So when we are providing 5 micromolar of this our drug, you could adjust high death rate apoptotic as compared to the existing drug ibrutinib. You can see this here and has difference between this drug and this. That means this specific, the targets are specific, and that's why it induces more apoptosis. Only apoptosis is one way of showing your molecule is more potent. The other way of showing the molecule having the potence is to whether it arrests the cell cycle at the proper stage. You can see where when we administer our drug, it induces G2M phase arrest, whereas the existing drug doesn't have much effect in the G2M arrest. So which includes which shows that the drug is potentially inhibit the cell cycle, and it checks the cell cycle. Once it checks the cell cycle, the cell cannot go to the next stage to proliferate. So providing this evidence, we came to know that this drug is totally inhibiting apoptosis or induce apoptosis and inhibiting the cell cycle arrest and induce cell cycle arrest. And then further we could able to see the protein level of these kinases after treating the drug. You can see that BTK expression is totally gone after treating with this molecule. And at the same time, another effector molecule of the BCR pathway is the phospho-AKT. You can see the phosphorylation level goes down when administrating with this. Whereas you can see a constant level of phospho-AKT in the existing drug ibrutinib. So here we can say that the drug inhibiting two simultaneously and inhibiting two different pathways. That's why it leads to to suppression of two different protein functions. And this graph shows, here is the mRNA expression. You can see the administration of the drugs leads to reduce some of the oncoprotein like c-MYC and BCL2. These two proteins are highly oncogenic in nature, and we can able to reduce the expression of the c-MYC. Once we stop the expression of c-MYC, it automatically leads to cytotoxic death or cancer cell death. The main hurdle, as I said, the main hurdle in front of us was to whether this molecule overcome the resistance. Because the data I am showing is just 1% of our work. I just put it here because it may be much for you guys. So I just put few of my works. So you can see that our main focus was to whether 3 to 6 to overcome this resistance pattern. So we have generated some of the resistance cell line for the drug, and we treated with our drug. You can see that treating with our drug, kill the resistance cell line most effectively as compared to this ibrutinib. So in other way, we have generated this cell line chronically, just exposing the cancer cell for a period of 6 to 8 months with this particular drug and making them resistant. When we treated the resistant cells with our drug, you can see there is a difference in the huge difference in cell death. That means our drug is inhibiting this resistance function that is induced by this drug, and our molecule would significantly suppress the resistance pattern by killing 50% of the cancer cells. So that seems to give us the idea that this drug is effective against the resistance platform. Next, we try to see the effect on this molecule on the in vivo mice model. So here you can see that we have induced these tumors in a mice system, and the mice were injected with cancer cells and they induced tumor. This is the control. You can see how big the tumor is. So these are the representative bar graph of these tumors. So this is the control one. And when you are treating with the existing drug, already well-known drug, ibrutinib, you can see the reduction of this tumor growth as compared to control. So you can see when we are injecting 60 mg per kg of our drug, 3 to 6 to, that there is a significant reduction of the tumor growth as compared to this control. So this shows that the drug molecule is highly effective to the mice bearing tumor, mantle cell lymphoma. So, but we need to check whether administrating the drug to the mice, the cancer-bearing mice, should not have effect on its body weight. So we have checked the mice body weight. We used to weight the mice body weight, and we didn't find any changes in the mice body weight. That means the drug doesn't affect the body weight loss. So next we try to see the protein level in the tumor. We just discuss this tumor and isolate the proteins. So you can see that level of this phospho-AKT and BTK, they are all going down. That means the drug is effectively killing the cancer tumor cells. That leads to decrease in the protein expression. So this what I talked is nothing but is a precision medicine. What is precision medicine? That is, it's a drug that increases the survival rate, that can target tumors with accuracy. As I said, that specific, target specific, and mitigate unnecessary treatment. Because if one drug is effective for a patient, there is no need of giving 3 to 4 drugs that ultimately give a cost effective and more pain to the patient, and ultimately reduce the prescription error. Maybe doctors are confused with the drugs, what to give, what not to give, or maybe a patient miscalculate or misunderstand the drug that given by the physician. So, lastly, I'll talk about the future cancer care and what will be the next cancer care. So it will be a huge, it's a huge challenge in front of all the researchers. Early diagnosis is very important to diagnose the stages of cancer. Then you can see if you want diagnosis properly, then you cannot treat cancer. If you diagnose in the early stage, you can stop the cancer progression. Managing cost and immunotherapy, as I said before, immunotherapy is the recent approach. Immunotherapy plus chemotherapy, immunotherapy plus targeted
ସେମିତି ଗାଧଉଛନ୍ତି ମାନେ ଦେଖନ୍ତୁ ଆମ ସାର୍ କି କେତେ ଇଣ୍ଟରେଷ୍ଟ ଲୋକ ସେ ୟାଙ୍କୁ ଶିଖିବା କଥା ଆମେ ଯେଉଁ ସବୁ କରୁନି ଯାଉଛନ୍ତି ଗାଧଉଥିବେ କି ଆଣି
important for cancer progression, so that you can hit those targets and reduce the cancer progression. You need to obtain the data, and in data into useful decision. So data representation also has a significant role in treating the cancer in future. So I will just conclude my talk. So, in conclusion, target therapy is more promising than the conventional therapy. The combination strategy, individual drug is useful, but have certain limitations. As I said, multiple single inhibitor and multi-therapy single inhibitor overcome drug resistance. That's where most of the research in the world is working on this, how to improve the drug resistance pattern, and effectively, hopefully, our drug will have the answer for this to overcome this drug resistance. So, thanks all. I will thanks my professor Ronald Gordon and my special thanks to Dr. Pavitra Mohan Bera, as you all know him. My senior Sweta Joshi, and all my lab members, as well as Dr. D.K. Garnai, Jain Pati, whom I know very closely, and S.S. Das, I know him for that. I got a lot when I was a bachelor student under him, and my special thanks to Dr. S.B. Kishwar for organizing such a nice webinar series, and hopefully the students will learn a lot from this series of webinars, and definitely they will bring some take-home messages after the completion of this talk. Okay, thanks all of you. So now we'll go for a question. If anybody have a question, please ask. Thank you. If anybody have a question, please ask or write in the chat box. Nobody has question? No students has question?
ପାଠ ପଢ଼ା ପିଲା ଦେଶ ସେ କରିଦେଇଛି ସାମନା କିଏ ଧବଳେଶ୍ୱର କିଏ ଏମିତି କାଟୁଛି ଦାଢ଼ି କାଟୁଛି ଖେଳିବା ଲାଗି ପଠେଇ
क्वेश्चन के पहचान दो
କେହି କ୍ୱେଶ୍ଚିନ୍ ନାହିଁ
Nobody has question? No students has question?
कि नहीं ମୁଁ କହୁଛି
ଆପଣ
Any
ପଚାରିବେ
question from faculty sides like
କହିବ
ଆପଣ
hello?
Any questions from participant sides? Okay, so thanks to Dr. Ranjay Pal. So your talk is valuable. Participants are students. So again, I thanks to you and participants and our principals and our organizing team. Okay, again, thanks to you. So now it is closed. Thanks to Dr. Ranjay Pal.